I attend for attendance. For medical practitioners, kindly fill in the Google form for CPD point. The Google form link will be given in the chat letter. Please be informed that this CME is live streamed via SASMAC YouTube channel. And if you have any question, you can type in the chat box or you can interact with the speaker during the Q&A session. Without further ado, I would like to invite our speaker today, Assistant Professor Dr. Abdul Majid bin Ghazali from Department Anesthesiology, Sultan Ahmad Shah Medical Center, SASMAC at RIUM, to give his talk with the title, Elderly Pre-Operative Assessment. Please welcome, Dr.
Bismillahirrahmanirrahim. Can you guys hear me? So let's start our presentation today, which is the topic of elderly, an overview of pre-operative assessment. So basically, in SASMAC, we have seen a lot of elderly patients coming to the OT, coming to the hospital, not only in the wards but also in the ICU as well as in the operation theatre. So most of them is actually not well managed, came in bad comorbidities, hence causing more morbidities and mortalities. So hopefully throughout this lecture, we can improve in terms of pre-operative and intraoperative, and of course into the outcome of post-operative to the patient. So in this lecture, I'll be talking about the general concept of elderly, physiology of elderly, the functional reserve, the fraility, and also prehabilitations and its outcome. So an elderly is defined by WHO with the age of more than 65 years old. However, in Asia, we do take lower cutting point of age, whereby we take more than 60 years old as an elderly. So this is an old paper from Prof. Mafauzi in USM in 2000, whereby he predicts that between 1990s to 2020, the age population is expected to increase by 210%. There are a lot of problems and challenges of the aging population in Asia. So what are the major problems predicted from the study? First is Alzheimer's disease, malnutrition, polypharmacy, and also lacking of rehabilitations from acute illness in tertiary hospital. So from Malaysia demographic data, we can see there is an increment of elderly, as you can see as at the above column, whereby there is increment from 2011 up until 2021, started from the 5.11%, increased slowly and slowly, and but now we do have around more than 7.45% as the data from 2021. So the issues that we have from elderly is high post-operative complications. This is study done by Petter in 2001, whereby they did a study, cross-sectional study for an elderly more than 65 years old in the colorectal cancer in a 31,000 studies. So the rate of them getting into the complications are significantly high for pneumonia, cardiovascular, cerebrovascular diseases, and also thromboembolism. There are also problems with delayed recovery for them in elderly age, whereby the rate for them to be at the par from the before the operation is actually getting longer and longer with the old age. Can be up from 3 to 6 weeks up until 3 to 6 months for them to recover back from the surgery itself. And other issue that we encountered in, for elderly is poor experience of care and facilities for post-operatively. Patient has more comorbidities and high incidence of frailty. So determinants of outcome of an elderly patient can be due to 4 factors. Number 1 is physical aging, and number 2 is comorbidities. Number 3 is extent of surgical stress. Number 4, elderly with specific issues, and also frailty. So in anesthesia, what we do concerns with elderly because of they are having these 5 problems that we need to be sorted out. Number 1 is consent, because they do have a cognitive dysfunction and the risk for developing post-operative delirium and post-operative cognitive dysfunction. At the same time, we need to assess their functional reserve and comorbidities, and we need to assess their frailty, their malnutrition, and also because of the comorbidities, they do have a polypharmacies that can result in intra and post-operative morbidities and mortalities. So in this overview lecture, there are 2 things that I will be talking. Number 1 is physiological aging, and number 2 is elderly with specific issue and also frailty. So, and at the end of the lecture, I'll be talking about the prehabilitations. So the physical aging is actually a concept of functional reserve, whereby there is a progressive decrease of functional reserve of an organ from time to time. So the study showed the physical decline will be 1% over 1 year after the age of 40 years old. So as you can see over the right side, our body started to decline in terms of function. And when there is a clinical signs of failure in any organs, it indicates that a person has a complete loss of functional reserve. So what are the physiological changes in elderly? So let's talk one by one based on the organ. So in cardiovascular, there will be reduced in autonomic responsiveness due to baroreceptor dysfunction, and beta adenoreceptor reduce in response. They will also reduce in decreased maximum heart rate due to the above factor. Hence, there will be preload dependency, and there will be increase in vascular stiffness, increased left ventricular wall thickening, greater dependence of arterial function for ventricular filling, and reduced response to angiotensin II, hence poorer response to fluid loss. So what happens if there is a bleeding that needs for flow demand? So in advanced age, there will be blunted of beta adenoreceptor responsiveness, hence resulting in the reduced or absent preload reserve, reduced or absent cardiovascular reserve, and they are at increased susceptibility to develop into cardiac failure. So in respiratory, there will be a changes due to aging factor. Number 1, there will be increase in vital capacity and reduce in residual volume because of these factors. Decreased strength of muscles, decreased lung elastic recoil, decreased shell walls compliance, and also there will be spinal collapse. At the same time, there will be increase in closing volume and closing capacity, increased VQ ventilation perfusion abnormalities, hence resulting in reduced in gas exchange, reduced hypoxic and hypercapnic reflex control, and most importantly, poor upper airway tone control that might cause a very high risk for them to develop into aspiration, and their breathing is more dependent on diaphragm. So when the closing capacity is the lung volume that close at after the normal aspiration, the closing capacity will be increased with the increment of age. At the age of 48 years old, 46 to 48 years old, the person can have a closing capacity same as functional reserve volume during the supine position, and if the age more than 68 years old, the functional reserve, the closing capacity is at the level of functional FRC at the upright position. So there will be very problem with the perfusion and ventilation later on because of this issue. In the CNS, there will be decrease in brain weight and volume, decreased neurotransmitter system, decreased neuronal gene expression, and Alzheimer changes. So what is the problem? The older age are more susceptible to develop post-operative cognitive problem. And then there are hepatic and renal changes due to the limited flow as well as the reduce in function, causing the problem with the drugs as well as the metabolism of the drugs, and reduction of excretion of the drugs as well as excretion of the any toxin from the body. And musculoskeletally, it can develop into osteoarthritis, osteoporosis, causing immobility and limits them for exercise, and increased incidence of thromboembolism. Poor stability can cause fall and ligamental laxity. And the changes in the drug can be from absorption, distribution, metabolism, and excretion. There will be marked reduction of these factors, and resulting in problems in terms of, for example, delay distribution of drug from plasma to biophase, and increased sensitivity to the drugs because of the brain is actually reduced in the neurotransmitter, unpredictable steady-state distribution volumes, reduced clearance as mentioned before, and prolonged elimination half-life due to inability for the organs to metabolize the drugs. But not everyone is actually defined as all having a very limited function of an organ, because all the elderly is actually heterogeneity. It doesn't mean if you are an elderly, you can become a person who has low capacity for with organs to work with. So some of the, as you can see over the picture, some of the an elderly can actually fit so much. The organ works like a young person, but some of an elderly population can be a very frail person that has no or minimum functional reserve, that anything can happen to him or her can result in fatal damage to her and him. So that's why we need thorough pre-operative assessment because of the heterogeneity in elderly population. So how to assess? So we can divide into based on the system: cardiovascular, respiratory, renal, and also CNS. So first of all, we would like to assess for integrated metabolic equivalence. So how this is an attempt to quantify the oxygen delivery and capacity to the patient. So it will estimate the likely outcome of surgery. So it predicts. So how we do predict on this? We predict on metabolic equivalent max. If it's more than 4, patient can sustain the stress of the surgery intraoperatively. The examples of metabolic equivalence, the score ranging from 1 to 10. So if score more than 4, like I mentioned before, patient can sustain the stress of the surgery. So if score 1 means patient can actually do the home course. So if the score is 2, if patient can walk a block on the level. If patient actually score 4, meaning patient can actually walk 2 flights of stairs. So 6 is moderate recreational activities. 10 is strenuous sports such as running, swimming, and everything. However, an elderly population actually has is actually a poor historians, so they tend to overestimate activities. So in a study done in 2001, compare the ability of a patient as a historian, most of them claim that they actually climb 2 flights of stairs, but actually they are living on the ground floor for the past 2 or 3 years. So that's why for them, it's actually for us to take the history as in to believe them 100%, it's actually we need to clarify carefully for us to the patient. How do we do? We can do the dynamic test. Unfortunately, this test actually is not available easily in hospital. I think the only place that has this test is actually at Sedang. So this is cardiopulmonary exercise testing, whereby a patient is actually tested in an exercise using a bicycle with an attached ECG and SpO2, and also carbon dioxide and oxygen sensor at the nose. So what we want to sense is we want to sense the anaerobic threshold, whereby with a patient, we want to see the oxygen capacity and delivery to the patient in a stress condition. So as you can see over the left side, if a patient has an anaerobic threshold less than 11 ml per minute per kilo, patient needs to be predispositioned to the ICU and has very high mortality up until 4.1%. If let's say patient has anaerobic threshold more than 11 ml per minute per kilo, however, with myocardial ischemia during the activities, patient needs to be admitted to HDU with mortality around 1%. And also, if in a normal condition, anaerobic threshold more than 11 ml per kg per minute without myocardial ischemia, this is very safe to the patient. So, the CPAT or cardiopulmonary exercise testing independently predicts the mortality of the patient and length of stay of patient in hospital. However, due to inability for us to do the CPAT test, we do have a test that is more dynamic and easy to do. So this is incremental shuttle walk test, whereby we put a cone in 9 meter in distance between each other. There is a 0.5 meter of the distance left outside. So a person needs to walk around 250 meters across the cone, and there will be increase in speed in between them. So the person will be attached with the SpO2 and also heart rate, and we will see the time for them to finish up the walking and between the two distance. So it correlates well with measured peak O2 consumption, peak oxygen consumption, and it has a good sensitivity for the patient it has good specificity and sensitivity to the patient to predict the post-op complication. So for each organ, we can actually assess one by one. For cardiovascular, we can assess signs of symptom of the myocardial ischemia as well as failure. We can also see the ECG, and failure we can see from BNP, and assessment of autonomic dysfunction by using lying and standing BP, and can also do in the clinic with the Valsalva maneuver. And respiratory, we can see the SpO2 lying and standing because of the increment of closing capacity. The chest X-ray for the patient. And for the renal, we use eGFR. We do not rely on the creatinine because, let's say, as you can example from below, 88 years old, came for colectomy, weight 40 kilo with serum creatinine of 100 micromole per liter. So as you can see, 100 micromole looks like normal, but then when we calculate creatinine clearance, it's actually stage 4 of chronic kidney disease already. So for CNS, we assess for cognitive impairment and risk of delirium based on the acute change in cognition and attention. It independently predicts the adverse outcome, whereby it can cause prolonged hospital stay, functional decline of activities, and risk of developing hospital-acquired complications such as infection, delay, prolonged insertion, as well as poor wound healing, and it has very high incidence for them to develop into cognitive impairment, around 10 to 20%, and most of them has actually associated with the risk of post-operative delirium. So we need to identify the risk factor for them. For predisposing factors, as mentioned, there are a lot: age more than 65, cognitive impairment or dementia, depression, and then precipitating factors can be because of the high-risk surgery, perioperative drugs, poorly controlled pain, anemia, blood loss, dehydration, post-operative complication, and also even an instrumentation to the patient and restrainment of the patient, impact oxygenation, alcohol withdrawal, and nicotine withdrawal. So based on this, we assess using abbreviated mental test. If the score less than 8 for abbreviated mental test, patient has high risk to develop delirium. And we can also test using 480 test. If the score more than 4, patient has high risk for them to develop into delirium. So next, we are talking about frailty. So based on BGA 2021, frailty is defined as a state of increased vulnerability to poor resolution of hemostasis after a stressor event. In an easy way, it's a geriatric syndrome whereby there is a reduced physiological reserve across multiple organ systems. Hence, they're causing diminished capacity to withstand external stresses, and they have a high post-operative complications, prolonged hospital stay, insertionalism, and also has high risk to develop into death. So as you can see over here, this is our over the picture. The bottom one is our physiological reserve. It's actually slowly being used during the stress. So when there is a stress and patient is frail, at the end of the day, patient becomes the functional reserve is reduced below the basal factor, hence resulting into death. Quantum physiology of frailty is postulated to have a role of inflammation and endocrine dysfunction, whereby the molecular disease and trigger because of the oxidative stress, telomere shortening, DNA damage, and causing impact physiological system. And clinically, we can see based on clinical frailty, whereby patient become slowness, weakness, weight loss, low activity, and also fatigue. So the effects of frailty, let's say a person below is a person with high frailty, above is person with no frailty. When there is a minor illness, patient can compensate well during the illness. However, when a person with a simple UTI coming to you with high frailty, patient can succumb into mortality and morbidities because of their function falls below the basal function. So comorbidities and frailty is not the same thing. Comorbidities is actually a set of disease associated with the person. Frailty is a general function of the patient. So even though you have a high comorbidities, but a person is not frail, it has normal function, no geriatric syndrome, normal cognition, and normal nutrition, a person has a better outcome post-operatively. If you see a patient with even low comorbidities, with very frail, having poor function, geriatric syndromes, impact cognition, and poor nutrition, a patient has very high poor outcome to post-operatively. So how do we assess frailty? It has multiple sets of assessment, but most easy or easily used for assessment, we can use NSQIP frailty assessment, Cognitive Frailty Scale, EDMONTON Frailty Scale, and Frailty Scale Comprehensive Geriatric Assessment. So for NSQIP, is based on American College of Surgeons, whereby it has 5 criteria. Pneumonia is swells, shrinkage, weakness, exhaustion, low physical activity, and slowness. So the interpretation of it, 0 to 1 is not frail, 2 to 3 is intermediate frail, 4 to 5 is frail. So this is a scale for second part, which is clinical frailty scale score. So it is based on a condition of the patient. So score 4 started to have frail. 4 to 9 is frail, 1 to 3 is normal. So this can be used easily in the clinic if you see the patient, because it is already suggested it can be used even as a normal doctor in the clinic. So Edmonton frailty scale using 9 criteria, but quite difficult. So the domain that we access using Edmonton frailty scale: condition, health status, burden of disease, function independence, social support, medications, nutrition, depression, continence, and functional program, in which it results in this score. So score 8 and above considered as frail and divided into mild, moderate, and severe. So frailty actually is very important because independently it predicts the post-operative complication, length of stay, and discharge to a skilled or assisted living facilities in patient which has frailty. And it also enhance the conventional risk of model, whereby if it combined with the ASA, it has better predictor of outcome for patient in elderly. So the role of frailty, we can re-stratify. We can mention to the patient the most probable associated outcome to the patient if the patient is actually going into the surgery itself, and we can actually proactively identify and optimize the patient and adjust their modifiable risk factors before the surgery. So how do we do that? We can do through prehabilitations and give good oral nutrition and supplementation, and at the same time we identify a patient with very high risk to have a poor nutritional support, and we can correct anemia and assess the delirium risk, and also manage coherently with a primary team, for example, medical as well, secretary. So what does prehabilitation do? In a normal aging, there is a reduce in functional physical functioning. When there is a stress or surgery, if it is not managed well, it will go below the basal functional reserve and cause high mobility and mortality to the patient. However, prehabilitation and rehabilitation can help them up into their functional reserve. Hence, the outcome will be better. So rehabilitation is a process of enhancing the functional capacity of an individual in anticipate of forthcoming physiological stresses. So actually it's a form of muscle strengthening. So it involves individual muscle strengthening, not only respiratory function, also can be involved with the mobility, muscle will involve in mobilization, muscle will involve with the eating and everything, because this will eventually helps the functions of each recovery of the patient. So rehabilitation does alter the mobility and motility, whereby when a patient undergo the prehabilitation, there will be there will be reduced in pulmonary complication. Can someone silent that? Reduce in pulmonary complication. There is also reduce in wound complications. So this is a case report in early 2012, whereby a frail 88 years old Sorry. Frail 88 years old lady with cardiac morbidity and has a prior episode of delirium. Undergo 3 weeks of rehabilitation and nutritional optimization. So post-operatively, no post-op delirium, improvement of exercise tolerance, and improve functional capacity of the patient. So what does the preparation or exercise rehabilitation for this patient undergo? So they undergo strengthening of each muscle, and by the upper body they do the shoulder flexion, horizontal abduction, shoulder blade squeezing, seated row, bicep and tricep curls. Lower body they do hamstring curls, ankle pronation, static quads, bridging, hip abduction exercise, breathing exercise, and they do a cardio exercise where they ambulate for 15 to 20 minutes each day. So the recommendation now, we do have a multimodal rehabilitation. It involves with the geriatric medical and also rehab team, and also nutritional team with the help of our hematology and also psychiatry to help in terms of anemia and psychological support. So in a medical optimization, we want the patient to have a very controlled comorbidities, control their sugar control their blood pressure, which is normal problem with the in elderly. So based on that, we optimize their pharmacological therapy and their polypharmacy, and we reduce the associated drugs that can be involved with the delirium. So at the same time, pre-operatively, we stop we do the smoking cessation to help improve in terms of lung function, suggestedly more than 6 weeks, because it can improve the ciliary function of the muscle of the lung and helps reduce secretion, hence reduce the perioperative respiratory adverse event to the patient. So number 2, we personalize physical exercise program. That's why most of the elderly I refer for individual muscle strengthening for the patient to improve patient post-operatively. So next is nutritional support. So nutritional support is actually very important because nutrition carries a good indicator for the patient to have a better post-operative outcome in terms of recovery, in terms of wound healing, and also in terms of having good biochemical factors, for example, hemoglobin, electrolytes, and everything. So we can actually assess nutritional support using NRS, nutritional risk assessment, and as well as in ICU, we do have Nutrit score. So basically, what do we see from the nutritional support? We do see from history and also biochemical. From history, we want to see any weight loss within 6 months, any reduce in appetite within 6 months, and we would like to know whether the patient is actually having albumin less than 30, and we assess through, and last but not least, we assess through nutritional risk assessment score, the NRS, as well as Nutrit score. So from there, refer to the nutrition. But the aim of nutrition is not only the calorie. The most important aim for nutrition is your protein. So the protein, as guided by ESPEN guideline in 2017, we need to maintain protein around 1.5 grams per ideal body weight per day, because our nitrogen cycle is around 1.3 grams per ideal body weight per day. So at least we can be up to 1.5 for them to build up the muscle to improve rehabilitation and improve the outcome of the patient. And last but not least, manage the anemia and also manage psychological support for them to have a better outcome, and as well as to reduce the delirium risk. So for summary, elderly is a special population that needs comprehensive care to improve intraoperative and post-operative prognosis. it needs multidisciplinary approach as early as the diagnosis is made and decisions to operative is discussed to help improve her or his condition. And frailty is a condition that can be reversed and treated with a proper planning between the multidisciplinary team. With that, I thank to everyone, and that's all for my presentation. Any questions?
Thank you, Dr. Majid, for your presentation. Right now, we open the floor for Q&A session.
Hi,
Participants
morning.
can write
Can you hear me?
their question in the chat box. If you don't have a microphone available, or you can interact directly with the speaker.
Good morning. Thank you, Dr. Abdul Majid, for such a comprehensive talk, whereby you summarize all the pre-operative management for those patients who presented with fragility injury. But what I found is you have only summarized those who presented for elective surgeries. How about those patients that require acute intervention for, let's say, acute injury? Because I'm coming from an orthopedic side, so most of our patients had the fragility fractures whereby we need to intervene acutely. So what is your recommendation for those patients? Thank you.
Okay. I think what Mr. Ko is actually asking is about the hip fracture, isn't it, Unko? Because the hip fracture commonly in elderly, and also they're coming with an acute condition. So for the with that kind of condition, it's actually it has been comprehensively discussed in the hip fracture study base in the ATOTW, whereby it also involves with multidisciplinary team involvement starting from the ED actually. So in this condition, patients needs to be managed in a multidisciplinary team. It involved with the geriatric team and also anesthesia team, because in elderly, like I mentioned before, the functional reserve actually reduced. They have a very reduced in functional reserve. So what happened when there is a pain occur to the patient because of the fracture itself? It can stimulate the sympathetic nervous system and cause higher demand of oxygen in the patient, causing increment of the function of the cardiovascular. But yet to say that, because the elderly cannot compensate on the demand of the condition. So we need to reduce that demand. So we need to control the pain first. So pain by right in emergency department, we need to give as recommended. Actually, we give nerve block in emergency department, and concurrently, simultaneously, the medical team should see the patient to manage accordingly with the optimization of the glucose and BP control, and the operation needs to be done as recommended by the island guideline around 36 hours based on hip fracture study hip attack study to improve the outcome to the patient. Is that answering your question, Ko?
Yeah, thank you, Dr. Abdul Majid. Just one more thing I would like to add, that based on what your recommendation just now, you have brought out one issue, which is early intervention is very important for this patient, because the metabolic cost for them is much higher compared to a younger patient. So based on studies, patients who have the intervention later than 48 hours after the injury, they have a higher 30-day and 90-day morbidity. So that's why for these patients, especially for fragility fractures in hip, we recommend early intervention. But unfortunately, sometimes we have our OT limitation. So we just need to ask for our help from the other departments, such as the medical and also NS side, so that we can together co-manage the patient before the surgery. Thank you.
Thank you, Ko.
I think if there's no other question, we can end our CME today. We'll wait for another 2 or 3 minutes.
One more thing. How about those patients that are not mobilizing and at risk of DVT and also pulmonary embolism? What is the latest recommendation?
That is for what case group?
For both elective and those patients with acute injury.
For recommendations for acute injury, the DVT prophylaxis, for example, the hip fracture, the DVT prophylaxis should be started after 6 to 24 hours post-operatively. But then, if the patient has an elective surgery, we do re-stratify for them to have the prophylaxis thromboembolism. But in elective surgery, the most important for them to have the prophylaxis thromboembolism is actually the elderly with obesity, because they can have the thromboembolic event perioperatively up until 4 weeks after the surgery.
Yeah, thank you. I bring up this issue also because there is a discrepancy between the medical side and the surgical side. So medical side, they have a recommendation based on the VTE prophylaxis CPG, which is in 2013, if I'm not mistaken. But coming from orthopedic side, we don't routinely follow that CPG, even though it's considered CPG. Because sometimes when we prescribe anticoagulant, what we found is there's a higher risk of infection and higher risk of hematoma formation post-operatively. So that's why we don't routinely start the anticoagulant for our patients. So we did more discussion on this issue between the discipline, because I found there's a huge discrepancy between medical and surgical side. Okay, thank you.
Thank you.
Okay, if there's no other question, again, thank you, Dr. Majid, for a pleasure being our speaker for today. I would like to remind the participant to register attendance in iAttendance, and for medical practitioner to fill in Google form through the link given. We end our CME today with Tasbih Kafarah and Surah Al-Ams.
Okay, thank you, everyone.
Thank you, everyone, for participating in our CME today. Assalamualaikum.